just like to say thank you to Malik Saab and Dr. Farhana for setting this up. So, we actually have a team that has come to treat a few patients with brain aneurysms. We thought this would be a good chance, as Dr. Zaidat is a world-renowned neurointerventionist. He's one of the pioneers in the field. So we said this would be a good opportunity to get some of his wisdom. So, subarachnoid hemorrhage, what is it? Usually it's a bleeding on the brain between the dura and the arachnoid matter. Typically, it's caused by brain aneurysms in 85% of cases. And patients typically will present with, worst headache of their life. Sometimes they don't have such a bad headache. Sometimes they'll have, a mild headache, which is called a sentinel headache. You have a little bit of bleeding from the aneurysm, but it's not a full-blown subarachnoid. So in those patients, sometimes you'll do the CT scan and it's negative, and then you'll do the LP to look for xanthochromia, and that's how you'll find it. But those patients are risky because the sentinel bleeds is a high risk for imminent bleeding. So usually you have a mild or moderate headache, and then you see a little bit of blood there. It's very highly likely that they'll bleed in the next 48 hours or 1 week or so. So typically there's a Hunt test grading for subarachnoid hemorrhages, which will classify patients if they have mild headache, if they have focal neurological deficits or coma, and that gives us an idea of what the long-term mortality.
Triple S. Size matter, I told them. Shape matter, right? Makes sense, right? Size and shape. And in this location, posterior basilar, if you remember the ISUA, that I did the same thing with the table. Trying to remember the percentage is hard, right? But as the size gets bigger, the rupture rate gets bigger. As you go from anterior to posterior, the rupture rate goes higher. So anterior to posterior is higher, meaning the basilar tip is the highest aneurysm that can rupture. And then the shape is irregular in this case. This is the aneurysm, and this is the angiogram. There is other option to treat. You don't have to treat it with web. We have the luxury to treat with web, but you have other options. So the other option that if you have it, you could try the cheapest option and the safest option, probably coiling. If you coil a bifurcation aneurysm, lots of water hammer effect that makes it come back. Compaction rate and recurrence rate is the highest in those aneurysms. So my favorite one is Penumbra 400 coil. We don't have it here. If you want to choose the coil, they're probably cheaper, faster, but they're thicker. They take more hammer effect. So in the posterior circulation, this is a good one because you need a thicker microcatheter from Penumbra. This way, it's a straight shot and it relaxes. But I thought maybe it looks exactly like the square web, and maybe one and done quickly. Here is another for people who want workshop, and there's also this.
Touch on the very basics of treatments of subarachnoid hemorrhage, that is surgical clipping versus endovascular coiling. And again, there have been the cornerstone of aneurysm treatment for a while. But there have been a lot of advancements in the past decade or so with regards to aneurysm treatment. And one of them is flow diversion. And I'll introduce the concept, share some cases, just go from there. So, flow diversion for treatment for aneurysms, the concept goes back about 2 decades at least, or more actually. But the idea is that as opposed to going inside the aneurysm, and again it's an endovascular approach, but as opposed to going inside the aneurysm itself to treat it, the idea is to remain within the parent vessel, place a device covering the mouth or the inflow tract of the aneurysm, and use it as leverage to heal the aneurysm. That's it. This case was actually done at your university. It was done here at Zaidat University. This was last March. This patient has been having diplopia. It's a left IC aneurysm. You can see it in the cavernous segment. Let me see if I can move the mouse pointer. No. So this structure right there, it's pretty visible to everyone. It should not be there. This is the cavernous segment aneurysm. And again, I'm not really sure how well you can see the screen, but there is a diverter right here. You see the outline right here? This is the